It's a pleasure to be with you today and go over with you how to get the most out of your Pentacam and for the cataract and refractive surgery using the Holladay report. And the Holladay report is something that we've worked on for almost 15 years with the engineers and people that have been with Oculus, and we've perfected that basically so it has all the information that you need and can quickly access when you're treating patients, so you don't have to spend a lot of time. And we know that you don't spend a lot of time at the instrument. The technician does that. And so this report provides you with all the information that you need. That is our purpose, to facilitate the presentation of information for the busy cataract and refractive surgeon to provide the highest quality care. So the handout for this you can get from the Oculus People USA, and on my website at Doc Holladay, the tab that has both the slide presentation and the interpretation guideline goes through all of the examples that we'll discuss today, and it has a narrative, a discussion that explains to you exactly how everything works. So you can go to Doc Holladay, go to the handouts, and those first two are the ones that you need to do that. And of course, the interpretation guideline, Oculus USA always has that available anyway for you to download from them. Now, the first thing that we go over, and we make sure that it's clear, is the display settings are absolutely fixed. And I show you that because if you look at this little picture on the bottom, on the left, I had a clinician send me Pentacam, which they do all the time, and I looked at that, and he says, Dr. Holladay, this looks absolutely normal. And I looked at it, and it was all green, and I kind of thought, well, you know, it is. And then I realized that the settings that he had chosen for the various scales were so coarse, were so insensitive, that everything that we wanted to show wasn't there. So we realized that making it so that every time you pull up the Holladay report, you'll see exactly the same thing at Clinic A as you'll see at Clinic B or anywhere else, because it's always the same. And those scales have been set so that they're sensitive enough for you to pick up every detail that you need, but not so sensitive that it overly detects things that you don't need. Now, there's a number of overlays that you need to be familiar with, and there are basically 5 that we show. The first is that black and white dashed perimeter that's the pupil margin that I show here as number 1. And notice that it's not necessarily a circle. It actually follows the pupil perimeter, so you see this little indentation down here, and that is a result of the actual perimeter of the pupil. The second thing is the black and white plus sign that you see right here, number 2, is the pupil center. It's actually the centroid, because what happens is we actually determine where the centroid of that perimeter is. If it's a circle, the center and the centroid would be the same, but we find the point that's the centroid of that perimeter. Now, the black and white brackets that you see, which is number 3 right here, is the limbal and iris geometric center. In other words, the geometric center of the iris, the visible iris and the limbus, is the optical center or geometric center of the cornea. And the 4th is the white circle with the black dot, that's number 4, and that's vertex normal. And that in a normal individual is within 5 microns of the visual axis where it intercepts the cornea. And people argue a lot about vertex normal and where the visual axis is, and you can't ever find it and stuff. And the fact is that it is, you can do it by construct and a ray trace, it's very close to vertex normal, and that's what I'm saying. It's within 5 microns of anybody that has a normal cornea that's not been operated on. And so you can assume that it's the visual axis, but the true name for that is vertex normal. And then the final parameter that we want you to recognize is the minimum pachymetry. And that's number 5 down here, and it's the small black circle. All right? So we'll have the pupil, we'll have the pupil center, we'll have the limbal center, we'll have vertex normal, and we'll have the minimum pachymetry. And those are the 5 parameters that we want you to recognize that you need to know in the overlays. All right, now here's what the report looks like. You'll notice there's 3 panels at the top. The demographics for the patient, thing that we have, the middle panel, it gives you information for the cataract surgeon as well as the refractive, and then this last panel gives you information that the refractive surgeon needs to pick up keratoconus, to pick up a thin cornea, and things like that. So those panels, and the first thing that we show is that after the demographics, the upper middle panel has this information. So the first thing we'll talk about is it has the K readings right here with the axes. And these K readings are not the standard K readings of the front surface. They're called the EKR 65, and EKR stands for equivalent K reading, and the EKR is about 11-year-old today, and it takes into account the back surface and the front surface. But that back and front surface value, we don't simply add together because that would be net power. And net power is less than keratometric power. What we do is determine the back surface power and then add that to the front surface. But all we do is take the difference in the back surface from normal, and if it's, say, 0.2 of a diopter more powerful, that would be negative. Then we subtract that from the K reading. And if it were less powerful, we'd add it to the K reading. So what that does is it means you don't have to change the A constant for any intraocular lens that's been manufactured today, because the K reading is accurate and it only adjusts for the back surface difference from normal. So now the 65 is another little tweak that we make, and we'll show you when we get to refractive surgery how that's valuable. But the EKR 65 is the best K reading to use today for standard and cataract and refractive surgery patients, because it gives you an equivalent K reading that's very accurate and can be used on any IOL, on any calculator that you do today. Now, the astigmatism is shown down here. The Q value is also shown. It's minus 23. And that Q value, as well as the total SA. Now, intraocular lenses are made aspheric today. And the aspheric values of those intraocular lenses are different. The one from B&L is 0. The one from AMO is minus 27, and the one from Alcon is about minus 20. Well, what you want to do is you want to match a patient's spherical aberration to the IOL. And this value right in this box tells you what the patient's is, so you'd like the intraocular lens to be equal and negative. So in this patient, either the AMO or the Alcon, because minus 20 and minus 27 are almost either side of that. It's actually better to have a little negative, so the AMO would be a little better there. Now, the back to front ratio that we have right there is 82.6. We show you that. And then this value is very critical also. The RMS HOA wavefront error over the 6 millimeter zone. And the reason that that's so important is that value can tell you preoperatively what the functional vision of that patient will be after cataract surgery. If that value is less than 0.5, the patient satisfaction will be wonderful, because their cornea will not be a limiting factor in the vision. If it's over 1.0, the patient dissatisfaction will almost be 90%. So over 1.0, you wouldn't want to put a diffractive lens in that patient, knowing that he's already got a compromised cornea. And between 0.5 and 1, it's in the yellow zone. It's like everything else that's clinical. Nothing is a straight line. It's always a yellow. So when you have between 0.5 and 1.0 microns of higher order aberration in the 6 millimeter zone, that patient, if they're very forgiving, will be happy. And if it's an engineer or a astrologist, somebody that looks at little points, they're not going to be happy. But the point is that value gives you an indicator of exactly what the corneal performance is, and it's very important. So the EKR65 you use for IOL calcs, that total SIA you want to match with the available lenses that are available today. RMS, the normal in the population is 0.37. At 0.66, patients are a little bit not satisfied, and greater than 1, the cornea will be the limiting factor in the vision, and they already have problems, so it's not wise to use a diffractive lens or any lens that splits the light because their cornea is already compromised. Now, that was the upper middle panel, okay? The upper right panel has this information. The first is it gives you the pupil diameter, and it tells you where it is. The second gives you the white to white, which you need for IOL calculations. It also tells you where the center of the limbus is, and that's important. But the biggest thing is the pachymetry min and where it is. Now look at this. This is 0.67 and 0.40, and it's relative to versatile. This is temporal, and this is inferior. And the point is, you'll see that whenever the pachymetry minimum is more than 0.61 millimeters below vertex normal, that patient has keratoconus, okay? Now, there's some other indicators we look at, but it turns out if you could only hang your hat on one, the location of the minimum pachymetry inferiorly is the biggest flag that that patient has keratoconus. Now we're going to see a hot spot, we're going to see elevation of the back, but that's a very important factor. Now, this refractive change here is something that tells you what the refractive change in a patient would be from refractive surgery. Now, it's plus or minus a quarter, so this patient's never had refractive surgery. But if that patient had had a LASIK and was -6, that value would be -6. And you say, well, how can you do that? I know the back surface radius. I know what the normal radius is of the front to back surface. So I can take the back surface and calculate what the front should be if it were normal, and take the difference between that radius and what it is today, and it tells me the refractive change from refractive surgery. So it's a valuable point because many of the lens calculation formulas today want to know what the refractive change was in the patient, and that value tells you that. And then chord mu is the distance from the center of the pupil to vertex normal, okay, and we'll see that's important. Now, when you look down here, these values, that chord mu should be on the average 0.2 on the Pentacam, and never should be more than 0.42. If that value is greater than 0.42, then that patient has so big a chord mu from the pupil center to vertex normal that they're not going to get good performance in a diffractive lens. It's an article that Amar Agarwal has written, and another one by a Czechoslovakian, but it just means that as the pupil center and vertex normal get farther apart, a diffractive lens requires that the rings be concentric with the pupil and that the lens is centered on the vertex normal. Well, you can't do both of those, and so as that gets farther apart, putting it halfway between compromises the result, and those studies show that if it's over 0.42, patients will have halos and glare and they won't be happy. So, that's the upper right panel. Now, the 6 maps that we're going to look at are in column 1, topography, column 2, corneal thickness, and column 3 is elevation. And we always have the color scale go from blue to red with everything in between. We don't use purple and magenta because purple and magenta, when you get done and look at that on the map, almost look the same. So you may have a 60 diopter cornea and a 30, and they look the same color because the magenta and the purple are close. So we don't do that. And I've done a lot of studies with doctors seeing what's the easiest thing for them to recognize, and this scale is the best. And the other thing is, if it's yellow, it's suspicious, and if it's red, it's abnormal. And if it's green, it's normal, and if it's blue, it's even better. Okay, so everything's easy. Okay, so here's the map. Now, the first thing we do is we look at these panels, all right? And we see on these panels up here that the spherical aberration is the same as we just looked at. These are the same panels that we saw. So let's look at the maps. The first map is the topography, axial and tangential. The second one is the pachymetry, absolute and relative. And the third is the elevation of the front and the back surface of the cornea. All right, so let's look at these. That's the first page of the report. The second page of the report is shown here. It shows you the K readings and a number of parameters, but the K readings from a 1 to a 7 millimeter zone, and graphs it for the 4.5 millimeter zone. Well, no, actually graphs it from 1 out to the 12 millimeters. And this is normal. This blue that you see here is the EKR, and you see in the normal patient it's kind of flat, then it gets a little steeple. This is the spherical aberration, and then it begins to taper off. So that blue curve, that's the normal. That's the way it ought to look in a person, okay? Then we take the EKR 65 from both the front and the back surface, and we show you that map. The red is the 4.5 millimeter pupil, and then this little graph over here is the distribution of power over that 4.5 millimeter zone. And you say, well, what do you mean? Well, over the 4.5 millimeter pupil, it's 4297 and 4566. Well, this is at 4297. Here's the 4566, and here's the power change in powers over the rest in between and what they look like. So this is the distribution of power over that 4.5 millimeter zone. And you say, well, why would you choose the 4.5 millimeter zone? And the answer is the average pupil size in mesopic conditions in the refracting lane with 5 to 10 foot Lamberts or foot candles of light is 4.5 millimeters, plus or minus 0.5 millimeter. So if you had to choose one pupil size, that zone is what the person uses in the refracting lane to determine his macular image. So what we want to do is calculate and fit everything to the zone that the patient's going to use when he's in the refracting lane, if you want to hit the bullseye in terms of an IOL calculation. So we do it for a 4.5 millimeter zone. Now, you've got that patient in the lane. You know his pupil size. And if it's not 4.5 millimeters and it's 3.5, well, you look at the 3 to 4 millimeter zone. And if that person is in the refracting lane and has a 6 millimeter pupil, well, then you go up here to the 6 millimeter zone. The point is the 4.5 is the average, but you know what that pupil size is on that patient in the refracting lane. All right, so that's page 2. Now, the EKR 65 we give you as a function of pupil size, so you can customize it. That blue curve is normal. That frequency zone shows you the distribution, and this is the normal distribution of a patient with astigmatism. And then we show you the EKR 65 power map so you can look at it, and that red zone is the pupil, so you can see what the power is within that zone. Now, the one other, well, so let's look at a couple of things. So IOL power calculations. All right. As I said, the EKR 65 is not net power. It's not the front and the back surface added together. Every intraocular lens formula does that in the first step of their formula and compensates and takes a 45 diopter K reading and then drops it down by about 3/4 to 1 diopter to 44, because we all know that the corneal power is less than the keratometric reading. So we drop it down And that's one of the differences in formulas. Binkhorst used a value, Holladay used a value, Olson uses a value. All of us kind of use a small different value for what the equivalent power of the cornea is because there's variation in the literature. But it's about a diopter less, and the point is the EKR65 compensates for that back surface. It takes, and if the back surface is a little stronger, meaning more negative, then we back off of the K reading by whatever that difference in the back surface is, so that the K reading that you report with the EKR is the same K reading you would get normally plus the adjustment for the back surface. So what happens is you don't need to change the A constants on all your lenses. The same A constant that worked for your standard keratometer, for the biometers that are available, will still work because it only adjusts for the back surface. Okay, so that basically is why you use the EKR. Now, for example, if the back surface was 0.3 of a diopter stronger, we'd report 44.7, not 45. And the net power would actually be 43.3. So equivalent K reading is not the same as net power. It's the adjustment for the difference in the back surface power. All right, now let's look at a couple of things here and see. All right, so first thing we do, we look at this and look at the segments in the 3 to 5, and 5 to 7 millimeter zone. Whenever you see these broken segments on the topography maps, you know that that patient has irregular astigmatism. A toric lens in this patient will not work well. Every time you put it in, you don't know the axis. You don't know the power because the patient has irregular astigmatism. Now, we actually would recognize that from those broken segments on the topography map. Now, just as an aside, the axial or sagittal power map measures from the center of the earth. So if I had a little bump right here that say was 10 feet high and it was a hemisphere, a sagittal map, that top one, would say it's 4,000 miles from the center of the earth plus 10 feet. That's the only difference that it would show, 4,000 miles plus 10 feet, and right over there it's 4,000 miles. So the difference between those two is negligible. It's only 10 feet and 4,000 miles. A tangential map or local radius of curvature map doesn't look for the center of the earth. If this has a 10-foot radius, it's 10 feet. If that's 4,000 miles to the center of the earth, it's 4,000 miles. So on the tangential map, it goes from 10 feet to 4,000 miles. So the tangential map is much more sensitive in looking at surface irregularity than an axial map. So you just keep that in mind, that sometimes this will be really broken and this won't be too bad. And the top one is the best measure, but the bottom one still gives you sensitivity for regularity. Now, in this patient, this is a keratoconus patient, okay? Now let's go back and look if we saw anything else there. All right, now, a couple of things that I recognize. Number one, he's got a little hot spot, but it's not where it normally should be. His minimum pachymetry is about, okay, pachymetry min is 0.78, and I said 0.61 is the maximum, so this guy's minimum is far lower. We look here, and he's got a relative pachymetry map of 7.1, and right here we see the posterior surface is 19 microns above the prolate ellipsoid fit, and about 17 microns on the front. Now, a couple of things are important. The relative pachymetry map. All right, we know that the normal cornea is thinnest in the center, and it gets thicker as we go to the periphery. It's a meniscus lens. It's positive radius on the front, a steeper radius on the back, so it's thin in the center, and it increases by a square, basically. It's a quadratic. It goes up by the square. So we can calculate what that should be. Well, if I know the central thickness and I know what it should be, I can use that to determine whether or not in the, say, right here where that's minus 7.1, I know what that thickness should be. So I can give you a percentage that says that that's 7.1% thinner than it should be. This point right up here is 0.5% thicker than normal, all right? And that yellow to dark yellow tells us that this is suspicious right here because it's 7.1%. Now, it's also where the minimum pachymetry is, and it's also where the hot spot is, okay? But that's not enough. The point is we're suspicious that this is keratoconus. We look over here and we see that that's 11 microns elevated on the front surface. There's a bump there, okay? But it's 19 microns elevated on the back surface. Why is the back surface more elevated than the front surface if it's just pooched out? Because as the lid goes over that front surface, it smooths out the epithelium, and the normal cornea has 4 to 6 epithelial cells that are about 4 to 6 microns thick. So the normal cornea is about 50 microns. But with the lid going over that little bump, it rubs off the top 1 or 2 epithelial cells, and now that little elevation up there is no longer 19, it's only 11. That's basically 1 cell thinner than on the front than it is on the back. And it's because the cornea has rubbed that down and trying to smooth it out. So the back surface is much more sensitive in terms of detecting keratoconus than the front because there's nothing to smooth it out. That elevation stays as high on the back forever, and it gets a little more each time it gets thinner. So what I'm saying is 19 microns is red, so that's definitely a problem. The 7.1 is suspicious. The pachymetry min has moved down, and a hot spot right there. This is keratoconus, no question. Now, this person is 82, 18, and this was taken in 2004, so they were basically 22 years old. You don't do refractive surgery on this patient because it's going to get worse. They're going to get ectasia. If they were 50 years old, you might consider a PRK because they've cross-linked for the last 30 years and their cornea is much stronger. So age is a significant factor in determining whether you do refractive surgery on somebody because younger people have much more elasticity and less cross-linking that's normal. As you get older, it cross-links. So the point is, in this 22-year-old, you'd never do anything like even a PRK, but if they were 50, you might consider it. All right, so now one more thing, and I get this in Iowa Calkins. I do about one of these a week for the doctors. Send me a map, and I say, and here's the mistake that's always made. They'll take a keratometry reading, come in, and the keratometry on this reading is going to be right here. It's going to be about 45 diopters on this person, okay? And they're going to do refractive surgery, cataract surgery, use 45 in the K reading, and the person's going to come out 3 to 5 diopters hyperopen. And the reason is, look at the distribution of power. He's got a 40.5 diopter peak and a 45 diopter peak. The 45 is this hot spot right here, and the 40 is everything around that. Now, what you'll find is, if you take this patient and say, okay, I want you to look at this near card, what you'll see him do is he'll pull that into about 20 centimeters, and he'll read J1+. Because he's got a bifocal cornea. He's got a cap, a 5 diopter cap, which is that cone that he looks through for near. And when he looks at distance, he doesn't look through that cap. He looks through the paracentral zone just like a refractive bifocal intraocular lens. You use whichever one, and when there's a 5 diopter difference, you use the one that's closest to in focus. And it'll be the 40 diopter is what that guy's looking at distance with, and the 45 is what the cap when he's looking up close. So what you do is you don't use that 45 or you'll come out hyperopic. It'll turn out to be nearer 40, and in the EKR 65, we weight those and look at that and use this part 65% from this peak, and it comes up to be about 42.5. That's the average power, not the 45. So we back down and we take that into account. So the point is, you should always remember that a keratoconic patient has a bifocal cornea, uses the cap to read it near, and you check that. You hold it, take a near card, and say, hold that up close without any glasses and read that for me. And if they read the J1 plus, you've proven that they're using the cap or near, and they're looking through the paracentral zone. All right. So the point is that EKR 65 works not only for keratoconus, but post-refractive surgery, PKP, corneal scars, anybody that has an irregular astigmatism, that algorithm for determining the 65% of the power and looking at the front and back surface gives you a much better estimate. Now, there's no question that it's not as accurate as a normal patient. A normal patient, you can get 75% of your patients within a half a diopter. That's the average today. With this, you'll get, depending upon the irregularity with keratoconus, it won't be 75% of your keratoconic patients. It'll be more like 50%. But it'll be the best estimate that you can do on that patient beforehand. Now look at this. This one on the left is a normal patient. Look at that peak. A 3 diopter spread is refractive power. A LASIK patient has a 5 diopter spread, and an RK patient has a 13 diopter spread in his power over the 4.5 millimeter zone. How do you expect to hit the same precision in a patient that has RK with a 15 to 13 diopter spread in his refractive power? You don't. You can't. So you have to prepare that patient ahead of time that the outcome that we're going to get with your cataract surgery cannot be as good as a normal patient because your corneal power is irregular. And you just work with them. And then there's things that we'll be able to do afterwards, but that picture on the right shows you why the RK patient is so hard, the LASIK patient is a little easier, and the normal patient is very easy. All right. So always use the EKR 65. The 4.5 millimeter pupil is the average. You customize that by looking at the patient's pupil in the refracting lane, and then you can go to that different pupil size when you've done that. Now, as we said, in the thinning disorders, the normal decentration of the minimum is about 0.19 millimeters, and when it's over 61, 0.61, that's diagnostic of keratoconus. And then we just looked at hot spots on the topography map, the relative pachymetry, and the front and back surface, and we know that the back surface is the most important. Now, when we look at this, let's look at something here. All right, we're looking at this patient. First of all, we see some broken Myers, not any dramatic hot spots, not any dramatic pachymetry, but that pachymetry min, once again, it's down 0.90, and, you know, a little yellow spot here, but nothing dramatic. Now, this is that patient's left eye, okay? Now, let's look at the right eye. Bingo, dramatic keratoconus, okay? So this is marginal when we go back, but when you look at the right eye, there's absolutely no question this is keratoconus. And keratoconus is almost always asymmetric. That's another clue that it's keratoconus, is that it's asymmetric between the two eyes. So what happens is, that first eye that we looked at, this one, you may say, well, gee, it's marginal. But when you look at the other eye, it's clear. So you always look at both eyes in a keratoconus patient, and you'll see an asymmetry, and if one eye's got it, you know that's keratoconus. All right, some other disorders. Let's see what we have here. We look at the axial power map and the tangential map, and what do you see? A crab claw. Okay, what is that? We see that the thinnest zone is not displaced. We see the relative pachymetry map, that there's a big thin zone right down here at the bottom of that. And we have this real big elevation and protrusion. So here's what it shows us. Here's the cornea, and it's bulged out at the bottom so that that profile looks like this. What is that? Pellucid marginal degeneration. So, but the crab claw is the diagnostic sign that you look at, okay? If it's got a crab claw, but I'm just saying that all of those elevations and the thin show you that that's what that is. Now, it's just as important in that, here's another example of that, to be sure to use the EKR65 for the power of an IOL calculation, because you've got to take that front and back surface and that zone into account. All right, another unknown. Okay, we've got some hot spots up here at the top. Right here, a ring of hot spots with a little low power down here at the bottom. We look over here and we see that the thinnest is in the center, and we see that this is 25% thinner than normal in the middle, and it's a bullseye, but there's no elevation in the back or the front. That's a LASIK patient, okay? Normal thin zone, the thinnest zone is still in the middle, but no elevation. That elevation on the back tells you whether there's ectasia. This is the left eye. There's the right eye. 35%, though it's thinner, but this right here, that 14 micron elevation on the back, tells you that's ectasia. Now notice the front. It's not even elevated because, number one, it's not keratoconus. That whole thing is bulged out, so it doesn't have a cap, but that back surface is 14 microns forward, so that guy should be cross-linked yesterday. All right, it's already too late, but you got to catch him. But again, you see how you use these colors and pictures to determine what's going on with the patient. So what I've tried to show you is how, for the cataract and refractive surgeon, when you go through these systematically, looking at the panels, looking at the maps, understanding what pictures look like, and that red is bad and that blue is good, that basically you can look at those two maps and determine for a patient within a matter of seconds exactly what's going on and have the information that you need to provide that good quality care that we talked about. So thank you so much for your attention, and I'll be glad to answer any questions that any of you may have about what we've spoken about.